But any clinician knows that a multiple choice test is essentially unrelated to the reality of clinical practice. And so one of the other things we looked at was the interactive part of diagnostic conversations with the patient. And so it was a major advance that we could pass a multiple choice test, and then 13 months later, we could do the study that I'm going to show you now. And because we have technologists and clinicians in the room, I'm going to explain the testing harness that we used, which is an objective structured clinical exam. And what you do here when we evaluate medical students and other trainees is we have standardized actors, standardized patients, and they know the script for what it's like to have lupus or breast cancer or heart failure or diabetes. And the medical student or resident goes in and they do a history and physical, and they come up with a plan, set of differential diagnosis and a plan. They're reviewed, usually by video by an expert who grades their technical competence. Did they get the right diagnosis? Did they make the right plan? But here's a critical part. The patient evaluates them for things like empathy, rapport, and connection. So our teams made a modified version of this where we had a bunch of these standardized patients and we randomized them to conduct an OSCE, an objective structured clinical exam, by text. And on the other end were board-certified primary care doctors or this model called Articulate Medical Information Explorer. Everybody got the study design, randomized trial, offline, standardized patients. And the model was clearly superior to the board-certified primary care doctors in diagnostic accuracy. Whoops. This plot shows if you got one guess at the diagnosis, how likely were you to get it right? The model is in red, the primary care doctor is in blue. If you got two guesses, right, so the task of differential diagnosis, primary care doctor model, and the model was superior across however many guesses you gave in the differential diagnosis. But remember, the patient also graded empathy, rapport, and connection. And again, in this plot, further out is better. The model was better on almost all of these dimensions, like empathy, rapport, and connection. And the important part is not the specific models. The important part is we went from being able to barely pass a multiple choice test to outcompeting board-certified primary care physicians in a text-based simulated OSCE in 13 months. That's how fast the technology is getting better. That's the anchor of that JAMA paper. And then I want to leave you with, what does today look like? This is a picture of a Nobel Prize. Two of my coworkers last year received a Nobel Prize for work in artificial intelligence in health for solving a problem of how proteins fold up. Why do we care how proteins fold up? Well, a protein is determined by a set of amino acids, and if it folds up one way, it causes cancer, and if it folds up another way, it may cure cancer. It's a very difficult problem. There's a thing called Levinthal's paradox that says if you take an average length protein and just fold it through all the ways it could fold up, it would take longer than the age of the observed universe if you folded it up 1,000 a second to get there. Like that, I'm no mathematician, but that sounds hard. The 2017 Nobel Prize in Chemistry was awarded for improvement in the ability to image the 3D structure of proteins. AlphaFold solved this problem, and it won a blinded international competition very clearly in being able to do this. It's a remarkable foundational biological achievement. And that's on the science part. And the next thing is, you hear AI scientists talk about multimodal. I want to give you a feel for what that's like. And so in my hotel room yesterday or the day before, I recorded me playing with one of these. We're going to see if we can get the audio to work.